There was history of 2 fractures involving femur and ulna in a duration of 1 year for which orthopedic intervention was done. So this was the X-ray at that time, which showed generalized medial bowing of femur, giving a shepherd crook deformity. There was reduced mineralization, and there was ground glass appearance in the right shaft of femur, favoring polyostotic fibrous dysplasia. At that time, which showed generalized. Her birth history was uneventful, with a birth weight of 2.5 kg. She was first born to non-consanguinely married couple. There was no history of similar complaints in the family, and she had attained all developmental milestones appropriate for age. On examination, all her vitals were normal. Coming to anthropometry, her weight was 16 kg, which was between 25th to 50th centile. Her height was 104 centimeters, which was between 10th to 25th centile. Her BMI was 14.79 and mid-parental height was 148 centimeters. On head-to-toe examination, there was facial asymmetry, hypertaylorism, depressed nasal bridge, broad forehead, and there was a right palatal swelling seen in the roof of the oral cavity. There was deformity of right eye. There was bilateral scar over hips due to correction of bowing of hips. There was no goiter or scoliosis. No, there was normal vaginal orifice with intact hymen. Other systems were normal. Her SMR was B2, T1, A1, and M1. Vaginal mucosa was pale. There were multiple Caffioli lesions on the back, the right gluteal region, and bilateral legs on the posterior parts. To summarize, she was a 5-year, 2-month-old girl having precocious puberty, Caffioli spot with fibrous dysplasia. So clinically, child looks like having McCune Albright syndrome. On investigation, the serum calcium was 10 milligrams per deciliter. Serum phosphorus was on the lower side, that was 2.8 milligrams per deciliter. Alkaline phosphatase was raised, that is 1420 units per liter. Free T4 was 1.22 nanogram per deciliter. Total T4 was 9 microgram per deciliter. TSH was 0.97 micro IU per ml. Her LH was 0.1. FSH was 5.33. Estradiol was increased. That was 29.5 picogram per ml. At 8 AM, serum cortisol level was 20 microgram per deciliter. Urine calcium creatine ratio was 0.05. Prolactin was normal, that's 13.74 micro IU per ml. Urea was 12 and creat was 0.18 milligrams per deciliter. So there was elevated alkaline phosphatase level with low serum phosphorus and increased estradiol level. On ultrasound pelvis, her uterus measured 4.6 by 2.3 by 2.9 centimeters. Endometrial thickness was 5 mm. Right ovarian volume was 2.2 cc and left ovarian volume was 1.1 cc. Her bone age at the age of 5 years, 2 months was 8.1 years, which was advanced. Leuprolite stimulation test was done. Her LH value at 0 minute was 0.01. At 60 minutes, it was 0.63. 120 minutes, it was 0.61. Her FSH value at 0 minute was 1.26. At 60 minutes, it was 4.16. At 120 minutes, it was 4.97. Estradiol level at 0 minute was 23.6 picogram per ml, and at 24 hours, it was 37 picogram per ml. So central precocious puberty was ruled out. MRI brain was normal. So coming to the diagnostic criteria for McCune-Albright syndrome, these are a few of the diagnostic criteria. That's fibrous dysplasia of bone, Caffioli skin lesions, gonadotropin independent precocious puberty resulting from recurrent ovarian cyst in girls, and autonomous testosterone production in boys, testicular lesions with or without associated gonadotropin independent precocious puberty, thyroid lesions with or without non-autoimmune hyperthyroidism, growth hormone excess, neonatal hypercortisolism. The presence of two or more clinical features are consistent with diagnosis of McCune-Albright syndrome. This child had fibrous dysplasia, cafe-au-lait lesions, and gonadotropin-independent precocious puberty. So the diagnosis of McCune-Albright syndrome was made clinically. Genetic analysis could not be sent due to financial constraints. Her precocious puberty was managed with selective estrogen receptor modulator, that is tablet tamoxifen 10 mg was given twice daily. For hypophosphatemia, she was supplemented with phosphorus and calcium along with active form of vitamin D. For fibrous dysplasia, bisphosphonate therapy was given. However, the child has been quite irregular for follow-up. Bone age continued to advance on follow-up and child went into central puberty. Hence, leuprolide was advised to her, but parents declined. There were multiple episodes of ovarian cyst, hence tamoxifen was continued. Bisphosphonate therapy was given for bone pain and control of fibrous dysplasia. So this was her follow-up. After the age of 5 years 2 months, they came next to us at the age of 7 years 8 months, and her height had rapidly increased, and she was 118 centimeters then, with weight of 21 kg. Bone age was 10.1 years. Her SMR had progressed to B3, P2, A2. FSH was 5.8, LH was 0.8, estradiol was 30 picogram per ml. They were non-compliant with medication. She had not even taken her phosphorus and calcium supplementation properly. So it was reinforced to her and tamoxifen was continued. Next, she came at 7 years of age with height of 120 centimeters and bone age was 12. SMR was B4, P3, A2. FSH was 6.55, LH was 19.98 and estradiol was 47 picogram per ml. So she had clearly gone into central precocious puberty. Injection leuprolide acetate was advised, but parents declined. Her next follow-up was at the age of 10 years 7 months, when her height was 123 centimeters. Her SMR was B5, P3, A2, and ultrasound pelvis showed presence of ovarian cyst bilaterally. Tamoxifen along with calcium phosphorus supplementation was continued to her. Next follow-up was at the age of 11 years 1 month with height of 123.5 centimeters. Her SMR was B5, P3, A2. At this point of time, she had undergone bilateral tibial correction osteotomy. Next presentation was at 12 years 9 months when her height was 123.5 centimeters. Her weight was 27 kg. Bone age was 13.5 years. SMR was B5, P3, A2. Bisphosphonate therapy was given to her. Her last follow-up was at the age of 13 years 5 months. That was in May 2024 when her height was 124 centimeters. SMR was B5, P3, A2, and she was continued on bisphosphonate therapy along with other supplementation of calcium, phosphorus, and active form of vitamin D. So this is her growth chart. Coming to McCune-Albright syndrome, it is seen because of post-zygotic somatic cell activating mutation of alpha subunit of G protein coupled receptor on the exon 8 of GNAS1 gene, which activates adenylate cyclase pathway. It is seen both in boys and girls, but mostly seen in girls. There is presence of triad of cafe-au-lait spots, polyostotic fibrous dysplasia that can involve any bone, can present with facial asymmetry and hyperostosis of base of skull. Hyperfunctioning endocrinopathy. Here, gonadotropin independent precocious puberty is seen, which is usually discordant. So when FSH and LH pathway are affected, there is precocious puberty seen, which is peripheral. If TSH pathway is affected, then there is thyrotoxicosis. Growth hormone pathway is affected, there is growth hormone excess. If ACTH pathway is affected, then there is repeat Cushing syndrome. If MSH is affected, then there is cafe-au-lait spots. So there is discordant telarche, menarche with no pubarche. Growth hormone excess, neonatal hypercortisolism or hyperthyroidism can also be present as a part of endocrinopathy. Hypophosphatemia or non-endocrine manifestations can be hepatocellular dysfunction with jaundice, hepatobiliary disease, and pancreatitis. Action. So aromatase inhibitors, that is anastrozole 1 mg daily and letrozole 2.5 mg daily have been used. Selective estrogen receptor modulator, that's tamoxifen 20 mg daily is superior to aromatase inhibitors. Estrogen receptor antagonists, that's fulvestrant 20 microgram per kg per month is highly effective, but it is limited by its high cost. So management of precocious puberty in girls, if bone age is advanced by more than 2 years and there is presence of frequent bleeding and or psychological distress, we have to give letrozole 2.5 mg daily. If this is ineffective, we have to add or replace with tamoxifen or fulvestrant. Monitor for and treat central puberty. If bone age advancement is less than 2 years with infrequent bleeding and no psychological distress, monitor for bone age, growth velocity, proper history and physical examination every 6 months have to be done. Gonadal evaluation in boys and men, targeted history taking and physical examination including the testicular volume, review the growth charts regularly, do bone age and testicular ultrasound at baseline and after 5 years of age. If ultrasound is normal with no microorganism, then McCune-Albright syndrome associated testicular involvement is unlikely. If ultrasound is abnormal with the presence of macroorganism, it is likely MAS associated testicular involvement. Suspicion for precocious puberty based on physical examination, growth acceleration, and bone age advancement has to be kept in mind. If there's elevated testosterone with advanced bone age, it is likely MAS associated precocious puberty. If lab values are normal and bone advancement is more than 2 years, it is possible MAS associated precocious puberty to consider other MAS associated endocrinopathy. If lab values are normal and no bone age advancement, then there is no MAS associated precocious puberty. The treatment for precocious puberty in boys is combination of testosterone blocker and aromatase inhibitor. Management of other endocrinopathies, for thyrotoxicosis, methimazole and radioablation also can be done. For growth hormone excess, somatostatin analog or pegosomat can be given. For Cushing syndrome, metirapone or rarely requires adrenalectomy. For low phosphorus, phosphorus has to be supplemented along with calcitriol. For secondary precocious puberty, GnRH analog have to be given. And for fibrous dysplasia and bone pain, zoledronic acid have to be used. Thank you.
Yes, thank you, Dr. Akshata. I think that was a very kind of a book presentation for McCune-Albright syndrome. Definitely, it's not possible that we have such presentations everywhere. Now, there are a couple of questions, Akshata. The first question is, does this child have multiple ovarian cysts and how common would ovarian cysts be in McCune-Albright syndrome? And why would they happen?
This child had ovarian cyst, which was recurrent, ma'am. So in a few of her follow-ups, there was cyst seen. So this is because of this McCune-Albright syndrome is because of somatic activation of the cells that is involved. So in girls, it is seen cyclically. So ovarian cyst can occur and it is recurrent.
Yeah, so usually do the autonomous activation of the ovaries, right? They'll just start producing a lot of estrogen from the ovarian cyst. So do they resolve on its own, or do we need to treat them? And so another question is, what is the preference for tamoxifen or letrozole? Which one is preferred?
Can I
Are you
request
talking about the
Professor Boyce to reply?
Yeah. Yeah, I'm happy to weigh in on that one in particular. The management of the precocious puberty was very controversial for a long time. There was a number of different aromatase inhibitors were tried, anastrozole and oh, the name of the other one is escaping me, but they were ineffective. So the tamoxifen was the first medication that was found to be effective, as an estrogen receptor antagonist, and it can be quite effective. After that, letrozole was tried, and unlike the other aromatase inhibitors, it actually worked quite well in a small phase 2 trial. And I think it's because it has a much higher potency than the other aromatase inhibitors. So, people had thought, oh, aromatase inhibitors are not effective in MAS, but I do think that one particular aromatase inhibitor does work. Personally, I prefer to start with letrozole, mostly because tamoxifen, it's a estrogen receptor modulator. So in some tissues, it blocks estrogen, such as the breasts and the growth plates. So it's very effective at controlling the precocious puberty. But it actually is an antagonist in the estrogen receptor in the uterus. So the girls will get uterine enlargement on treatment. And there is at least a theoretical risk that maybe that could increase risk of uterine cancer down the road. So I typically will start with letrozole, and then I add tamoxifen if the letrozole won't be effective on its own. But I think tamoxifen is also a very reasonable choice. A lot of people use them, and it works quite well.
Is it all right if I have a question? So I've had some McCune Albright where I just start with tamoxifen, and then when they break through, I add on letrozole for a short while and then go back to continue tamoxifen. But there are some who don't respond to both. Have you had any occasion? Because I had one girl who used to have huge cysts. It's like 25 centimeters across. And we had to repeatedly aspirate under ultrasound guidance. At puberty, the parents decided to sacrifice the ovaries rather than their child going troubled.
Yeah. There's this, it can be really difficult when the cysts get large like that. So I've had in my experience, the vast majority will respond very well to letrozole, and then only a few require both. But there is the occasional one that I know what you're talking about, because none of the medicines will stop the cysts, unfortunately. The cysts will come no matter what you do. All the medicines will do is block the estrogen from causing clinical problems. So occasionally you'll get a girl that, for whatever reason, just has very aggressive cysts. I just think it maybe has something to do with the mutational load in the ovaries. So I have had one case where I added fulvestrant on top of letrozole and tamoxifen. And that's nice too, because they all have complementary action. The letrozole will block the estrogen production. Whatever sneaks through, tamoxifen and fulvestrant will help block the receptors. But I haven't found anything that will help with those just super large cysts. I think aspirating them is really all you can do if you have to, with the hope that you'll still preserve some ovarian function. But I've had a couple of those girls where they do end up with premature ovarian failure, probably because of repeated torsions or just damage to the ovaries. But only a few. It's quite rare. I think you are a bit unlucky there, Dr. Ayahu.
So then how long do you continue the
when do we
medicines?
decide to stop letrozole and tamoxifen?
Yeah, it's there's no clear guideline there. Typically, I will treat the kids a little longer than average, just because in some cases, when you stop the medicine, the puberty can just roar very quickly. I usually tell the parents we should prepare that they will start menses right away when the medication is stopped. So usually 9, 10 is a little bit young. I will often try going to 10 and a half or 11. And if you're worried about height, you can try to stretch it a little bit longer, but generally 10 and a half is about the youngest I'll stop.
And have you noticed these recurrent cysts interfering with the central puberty? Like when they
Yeah.
start their periods and everything?
Yes, it can, because we noticed that because some of the adult women with MAS were having quite problematic periods, quite irregular bleeding, and then some issues with fertility. And from what we can tell, it seems to be that, that these cysts continue really at the same frequency in adulthood. Most of our women do require some type of medication to help manage the cysts. Otherwise, they can end up with even at high rates of anemia, and some women even opting for hysterectomies to try to control the bleeding. I have found that the progesterone containing IUDs work really, really well in those women to make them more comfortable. I like them because I always have a bit of a worry with using things like oral contraceptive pills. They can regulate the menses okay, but you are really giving more estrogen. And when they have the cysts, they're already getting pretty high estrogen levels. So I like the IUDs because they're kind of less invasive. They just stabilize the uterine lining without adding a lot of extra hormones systemically. And then we usually tell women that certainly pregnancy is quite possible, but it may take a bit longer because they have to wait for a cycle that's not getting interrupted by a cyst.
So Jala, can we take the last question for Akshita?
Yes, ma'am, we have time.
Yeah. So Akshita, the question is, why were the alkaline phosphatase levels so high? And does it tell us anything about the severity of fibrous dysplasia?
In McCune-Albright syndrome, there is the hypophosphatemic rickets seen. So ALP is indicative of bone turnover. So ALP will be raised. And FGF23 mediated phosphaturia, it tells about the severity of fibrous dysplasia.
And any active or increasing fibrous dysplastic lesion can also cause these high alkaline phosphatase levels. It indicates that these lesions are progressing or new lesions have appeared. So I think, Jhalak, that's all from us. And we can have our next case by our very dear friend, Dr. Linita. So with pleasure and a lot of pride, I introduce Dr. Linata. She's a senior consultant in pediatric endocrinology at Rainbow Children's Hospital, Hyderabad. She is the faculty in ISPAE Diabetes Education and Learning, that is the IDEAL program, and has been a certified, which is a certified diabetes educator course since 2021. She has been the co-organizer of pediatric diabetes for postgraduates, that is the PDP, which is interactive workshops aimed at pediatric postgraduate trainees and practicing pediatricians since 2019. She has been a founder member and ex-secretary of the Thalassemia Support Foundation, which gives comprehensive care for underprivileged children with thalassemia. And she was a co-founder and co-organizer of the multidisciplinary clinics for children with thalassemia. So, Linita, welcome, and all over to you now. You're on
Linita,
mute.
you're
Thank you, Shalmi, for the introduction. Thank you, everyone, for still being on and listening, and an interesting topic. So the next case is, again, a McCune-Albright case, but this is a case which actually starts at the age of 2.5 years and progresses on till the child is actually 9 years. And this is going to be presented by Dr. Praveen Paul, who is currently in his 4th semester at AIMS Delhi doing his DM-Ped endocrinology. He's done his medicine, DCH and MD at Vellore Medical College. And without any delay, I'll hand it over to Dr. Praveen.
Thank you, ma'am. Are my slides visible?
Yes, they can be seen.
Yeah, sure. Thank you, ma'am. So I'll start with the presentation.
Just a minute. If any questions, if you put them in the chat box, we'll answer them at the end. Go ahead, Praveen.
Yes. So I'll be presenting a 9-year-old boy from Delhi who's presented to us at 2.5 years of age with complaints of recurrent fractures from 1.5 years of age. So the fractures were predominantly of the lower limb, the left femur, lower end of tibia, right fracture. He had sustained about 10 fractures by about 2.5 years when he came to us. And there was progressive deformity of both the legs, and there was also history of bone pain. The first fracture had occurred while he was playing, but subsequently the parents reported that they were actually low trauma fractures. Towards asking for the history in a child who comes with recurrent fractures, there was no history to suggest a renal tubular acidosis. There was no history to suggest a chronic liver disease. There was no history of a dental abscess, which should have been a clue for hypophosphatemic rickets and deformity and fractures. There was no history of any urinary complaints, headache, or seizures to suggest a chronic kidney disease with hypertension. And there was no history to suggest malabsorption as would be seen seen in celiac disease. And in a child with bone pain, fractures, there was no history of blood transfusion to suggest a malignancy. Going on to the antenatal and the birth history, as you can see, he had a very uncomplicated antenatal period. He's the firstborn child of a non-consanguineous marriage. He's a developmentally normal child. He has a younger sibling who's also well. And there is no family history of any recurrent fractures or any skeletal deformities. So going into the examination of the child, in appearance, he appeared short. He had macrocephaly with a parietal prominence. There was no dysmorphism. The eyes, ears were normal, and he had a small, soft goiter. As you can see in these pictures, he had large cafe au lait spots with irregular macules with irregular margins. On the chest, it was lateralized to the left side, and in the left arm, as you can see, he had it over the lower back, over the buttocks, and over the genital and the inner region of the thigh. On examination, though he had a small goiter, he did not have any tachycardia or hypertension. His height and weight were at the minus 2.15 and minus 0.8 SD. His systemic examination was unremarkable, and he was prepubertal, as in his stretch penile length and genitalia were appropriate for a 3-year-old child. So our clinical diagnosis in the first visit, this is a 2-year, 10-month-old child who presented to us with about 10 fractures. On examination, found to have large cafe au lait macules, short stature, a soft goiter, small goiter, and deformity of the legs. So the possibilities that we considered is McCune-Albright syndrome with fibrous dysplasia, and in view of the skin lesions and deformity, other possibility that we considered, the clinical possibility that we considered is an epidermal nevus syndrome with hypophosphatemic rickets. Those skin lesions were not very characteristic. Going into the examination, as you can see, the blood counts were normal. His renal function was normal. His calcium and phosphorus was normal. He had an elevated alkaline phosphatase of 939. His PTH and vitamin D was normal. He had a suppressed TSH with a free T4 of 1.24, which was normal, and a T3 of 580 nanogram per deciliter, which was high. He had FSH and LH, which was prepubertal, and a testosterone level, which was normal, taking the reference to be less than 20 in a 2-year, 10-month-old boy. As you can see, during the first presentation, he actually came to us in a cast, and there was a fracture of the lower end of the tibia. So in view of the high alkaline phosphatase and skeletal deformity, we also looked for whether he had renal phosphate loss. So using the formula, his TRP and TMP GFR was calculated. The TRP, the renal phosphate threshold, was calculated to be 95.3%, and his TMP GFR was 4.19 milligram per deciliter. Taking the normal reference for the age to be between 3 to 5, we can say that this child does not have renal phosphate loss at this point. So because he had macrocephaly with slight facial asymmetry, a skull CT was done. As you can see in these yellow arrows, there was multiple fibrous dysplastic lesions in the base of the skull, suggestive of polyosteotic fibrous dysplasia. As you can see, the base of the skull, the temporal and the parietal region. He had a small goiter. We did a thyroid ultrasound, which showed a slightly enlarged gland with multiple heterogeneous hypoechoic nodules of varying sizes with anechoic regions in between. The largest nodule was about the maximum diameter was about 13.9 millimeter. And a Doppler was done, which showed increased vascularity of the entire gland. So we went ahead and did a thyroid scan, which showed increased trapping function, suggestive of a hyperfunctioning thyroid gland. What I've not mentioned previously is that we have not done a TSH receptor antibody, but the anti-TPO antibody was negative in this child. So now coming to the diagnosis, after the investigations, the possibilities now was McCune-Albright syndrome with polyosteotic fibrous dysplasia presenting with recurrent fractures and biochemical hyperthyroidism. So as discussed in the previous presentation, this is the diagnostic criteria for McCune-Albright syndrome, and we need to satisfy at least two clinical criteria. The child that we are presenting had polyosteotic fibrous dysplasia, had cafe au lait skin pigmentation, and had thyroid lesions with features of hyperthyroidism. However, he did not have precocious puberty, growth hormone excess, or neonatal hypercortisolism in history. So, the diagnosis of McCune-Albright syndrome with polyosteotic fibrous dysplasia was established. And initially, the child was started on bisphosphonate therapy. He received one dose of pamidronate, which was then followed up with zolindronate infusion once in 6 months. And for the hyperthyroidism, he was started on oral carbimazole. Now, 1 year later, when the child was 4 years and 2 months, he was noted to have an increase in the phallic length. The stretch penile length had increased from 3.5 centimeters to 5.5. The testicular volume was bilateral 4 ml. The FSH and LH, though the testicular volume was about 4 ml, the FSH and LH was prepubertal. However, the testosterone level was slightly elevated and bone age was increased to 5 years. So, taking into consideration the clinical picture with the low FSH and LH with an elevated testosterone, the possibility of a gonadotropin independent precocious puberty as seen in children with McCune-Albright was considered, and the child was started on letrozole at a small dose of 1.25 mg once daily. 6 months later, as in we were following up after 3 months, and then at 6 months, there was no increase in the phallic length or any increase in the testicular volume. The testosterone level was, however, 37.7. There was no progression in the puberty clinically, but there was a mild increase in the testosterone level. The letrozole dose was made to 2.5 mg OD now. And after that, the testosterone level came down, and there was no further progression in the puberty or in the bone age. And therefore, the dose of letrozole was kept at 2.5 mg, and that was continued. 2.5 years later, that is when he was 6 years and 10 months old now he was noted to have increase in the stretch phallic length with stretch penile length of 8 centimeters now. As I mentioned, he was only on letrozole for nearly 2 years, and he was sort of maintaining. The precocious puberty was controlled with it, and this time he was noted to have FSH and LH which was in keeping with central precocity with an elevated testosterone level. So at this point, he was started on bicalutamide. What we thought was we would initially start him on bicalutamide and then observe and see whether he actually requires leuprolide as well. However, after starting on bicalutamide, the testosterone levels had come down, and the FSH and LH had also come down to the prepubertal levels. So, going through his course over the last 6 years that he has been following up with us, the first aspect, that is growth. So initially he was growing along the 3rd centile, but however from the 5th year of life, as you can see, he was initially plateauing, and then he has been faltering on his growth on the growth chart. His current height SDS is about -3.3 and his BMI is -1.1 SD, whereas his mid-parental height stands somewhere between the 50th to 75th centile. With respect to fractures and deformity, so as I had mentioned earlier, initially we had started him on zoledronate, and then as in initially one dose of pamidronate followed by zoledronic acid once in 6 months. However, the frequency of the zoledronate was decreased subsequently as the bone pain had come down and the fracture rate had decreased. Over the last 5 years, his fracture frequency had decreased significantly. He had actually come to us with nearly 10 fractures over a period of 1.5 years. Over the last 4 years, he's had 3 fractures, and the last fracture was in August 2023. There's significant decrease in his bone pain, and currently, actually, that's not a concern to the child as well. So, in view of the extensive polyosteotic fibrous dysplasia, we need to continuously monitor the metabolic status and also look for renal phosphate wasting. So this is done in the month of September. So as you can see, again, his calcium profile is normal. He's on letrozole. So we have done a liver function test, which is also normal. The alkaline phosphatase is still elevated at 710. His PTH and vitamin D is normal. And currently his TMP GFR is 3.38 and taking the reference for the age to be between 3.1 to 5, we can say that at this point either he does not have any evidence of renal phosphate loss. This is the deformity. Unfortunately, he has progressive deformity of the lower limbs with a significant coxa vara. This was his X-ray at 7 years, and as you can see right now at 9 years, he has a significant worsening of his coxa vara deformity, and this is probably what is leading to his height being compromised as well over the last 3 years. He was evaluated recently by the pediatric orthopedic team, and he's been planned for a corrective osteotomy surgery in November 2024. That is 2 months later. He's been dated for a surgery. So, with respect to the growth and the deformity, with respect to his thyroid function, as I said earlier, at diagnosis at 2 years and 10 months, he was started on carbimazole. And based on his thyroid function test, the dose was titrated. And presently, on last follow-up in September 2024, his TSH was 2.7 and his free T4 was 0.89, and thus the dose of carbimazole was further decreased. With respect to the precocious puberty, the first sign of precocious puberty was at 4 years. After that, when he was started on a small dose of letrozole, after that we had to increase the dose slightly of letrozole. And then at around 7 years, when there were features of progression in puberty, we had started him on bicalutamide as well. And currently at 9 years, his LH is 0.1, his testosterone is 22, and currently his bone age is sort of consistent with his chronological age of 9 years. So, coming to the last slide, which is our follow-up plan for this child. Definitely we need to look, considering that he has very significant extensive polyosteotic fibrous dysplastic lesions, we need to follow him up for development of hypophosphatemic rickets, both clinically, TMP GFR as well as FGF23 levels. With respect to the deformity that we had, I think we were already slightly late with planning the surgery. He was advised these lower limb prostheses, which he has not been using. So plan is for corrective surgery next month and then compliance to the prosthesis. And bisphosphonate therapy, if there is a recurrence in the pain or an increase in the fracture frequency, thyroid function test to follow up the thyroid status and adjustment on the carbimazole dose, and of course ultrasounds also to look for evolving thyroid nodules. Control of the peripheral precocity with letrozole, bicalutamide, and other agents, and also definitely looking for features of progressing into central precocious puberty, and screening for growth hormone and cortisol excess, both clinically as well as biochemically if warranted. So this is my case.
Thank you, Praveen.
Srinitha ma'am, we have some questions in Q&A section. We
Yeah,
can take those up.
I will
Thank you.
open them up. Praveen, are you ready?
Yeah.
Okay. So at 9 years, the normal HPO axis is stimulated. So how to differentiate it as normal from secondary central precocious puberty?
Ma'am, I think at 9 years, that is right. As in, even if we were to see a LH of 0.4 or 0.5, it would be hard to differentiate between central, whether it is just the natural course of central precocity setting in. So I think the decision on whether we need to suppress puberty or not would depend on the height that we are targeting. And I think it is not just going to be the secondary sexual characters. Like for this child, I think once we have the corrective osteotomy done, we would want him to grow longer. So we would want some more time before which he has significant exposure to sex steroids and this. So I think to answer that question, I'm not sure whether it is right to say that we need to suppress puberty at 9 years or not. I think the decision should be based on other factors as well.
It will be a case-to-case
Yes.
basis. Next question is, what is the endpoint of letrozole treatment? What are the parameters to be monitored?
The parameters to be monitored would be the liver function test for letrozole. Again, over here, the decision on whether to stop letrozole would depend on when we decide to let the puberty continue. So I think the same answer applies here as well. When we decide to pull back on the letrozole and bicalutamide, it would depend on when we are making the clinical decision of allowing this child to progress into puberty.
Another question here. Physiologically, adding letrozole seems counterproductive in boys with precocious puberty as it will increase testosterone levels. Should bicalutamide have been started upfront instead?
So, ma'am, I did look up something, and maybe you can add to it as well. The first line of treating generally most of the experience with peripheral precocious puberty is actually extrapolated from testotoxicosis, because generally it's quite rare in peripheral precocious puberty in boys is otherwise quite rare. So generally they say starting with spironolactone or testolactone with letrozole would be the ideal way to do it, where you're using one agent to sort of reduce the testosterone levels and another agent to sort of prevent the bone age advancement. In our child, actually, the testosterone levels were just slightly high with a slight increase in the bone age. So we actually started with letrozole, and actually we sort of saw a good response to that. There was no progression in the puberty. And I wasn't there at that point, but I think the thought process would be that we did not think of adding a second agent at that time because the peripheral precocious puberty wasn't troubling us too much for almost 2 years at a small dose of 2.5 mg OD. And after that, we started bicalutamide when there was a progression in the puberty while on 2.5 mg of letrozole. But as to should we, I think if the puberty was more progressive, I think definitely we could have started bicalutamide as well in the first few months.
And if I could just add to that real quick, I totally agree. We usually start them together because one will block the testosterone from causing symptoms and the other will prevent the bone age from progressing. One point I wanted to make too is I saw that you started the letrozole 1.25 milligrams and then increased the dose. I think some of that has come from when the very early studies of letrozole in kids, we used half of the adult 2.5 milligram dose just because it makes you a little nervous to just use an adult dose in a very small kid. But as part of those studies, they found that kids actually metabolize letrozole a lot faster than adults. So I will typically use 2.5 milligrams in every kid, no matter how small, even in like 1 and 2 year olds, because I just have never found the 1.25 to be quite effective enough. So,
I think, ma'am, even in our case, we had to in about 3 months when we had followed up the child, we had to increase to 2.5, and with 2.5, he sort of responded.
Yeah, and one other point I wanted to make is it's tricky to know how to follow them once you have the medications on. I personally, I don't, once I start a medication, I don't tend to follow the labs too closely anymore, because I don't find that it really changes the management. I think once you start the treatment, your endpoint is really the bone age, the growth, as much as you can tell with femurs bowed like that. Growth is a very hard metric to follow, and the pubertal exam. So I don't think it's wrong to get the labs. I think that they can help, but I often find that sometimes the children will be beautifully controlled clinically, even if they still have high testosterone. And I think to me that is okay. You know, at the end of the day, we're treating the kid, not the labs. But it does illustrate how this can be complex. Mhm.
There's one more question.
Mhm.
No, there are a couple more. So
Mhm.
improvement in fracture frequency, do you feel it's effective of bisphosphonates treatment, or is it because of improvement in the pathology as it stabilizes with time?
I think it might be a bit of both because even fractures have a waxing and waning course. And generally, I think the older they get, the lesser is the fracture frequency, even in the natural course of the disease. So I don't know whether I'm not aware enough to say that to attribute the whole benefit of the decrease in the fracture frequency to the bisphosphonate, but definitely it benefited the pain. And I'll just pass on the question because I'm not very sure of the answer. Actually.
Well, I think that makes sense too. Fracture frequency is a tricky thing to follow because it's one of those diseases where, just like you did, you have to pair with the orthopedic surgeon, because especially the femurs, it becomes almost just a structural issue. Once they bow past a certain degree, they're just going to keep fracturing because the angle of the femur is unstable. So I don't know that it means we're doing anything wrong on the endocrine side. I think it's a sign that the surgeons need to go in and put some hardware and kind of make the limbs straighter, and that will decrease the fracture frequency too. For this little boy, I wondered, is he still walking with the coxavera angles?
Yes, he's
Okay.
ambulant.
Well, that's great. Yeah, he's a tough little guy. Those are some serious looking legs. Sometimes the fracture frequency will go down because the kids aren't walking anymore. So it's, you know, it's again sort of like the labs in precocious puberty. It's one piece of information, but it doesn't always control it. And it's helpful too with the pain management. You know, the bisphosphonates can certainly be helpful, but the pain in FD, it can arise due to just, it can drive due to structural issues where really it needs to be addressed by a surgeon. Sometimes the pain is because the phosphorus is low and it responds to treatment with that. And if both of those have been tried and they still have pain, the bisphosphonates can be helpful. So I think it sounds like this little boy benefited well from them. And it's good you're pairing with the surgeons, because at the end of the day, I think what his legs really need is an osteotomy, more than anything that we can do on the endocrine side.
Ma'am, if I were to ask, like, when do we make the clinical decision of stopping the bisphosphonate? As in, like, for example, in this child, his fracture frequency has come down, he's pain-free. We have sort of uh, like stretched out the bisphosphonate frequency to like about 9 to 12 months now. When do we decide to stop it?
Yeah, I have a slide too. I'm happy to share with folks about recommendations for that. But in MAS, I'll talk about it in my talk too. We don't expect the bisphosphonates are going to help the bone quality, unfortunately. They don't seem to make the bone stronger or change the nature of the bone lesions, but they do mask pain or help with pain. The reasons aren't entirely clear. Bisphosphonates through the IV form help a lot of different types of bone pain. So typically the way I will treat them is I only use the bisphosphonates for pain, and I will give them a dose of, you know, either zoledronate or pamidronate. And then rather doing a set schedule, I usually say, come back when the pain is back. And sometimes it varies. Some kids it lasts a few months, some kids it may last a year. Sometimes they may have a surgery in between and now they don't have pain anymore. So I think the nice thing about that approach is they're going to have FD for their whole lives, and they may benefit from bisphosphonates at multiple periods in their life. And that way we avoid giving them too many bisphosphonates when they're so young, so that they'll have reduced toxicity and less likelihood of getting, osteonecrosis of the jaw if they need it as an adult.
I have a question. So how could you help a child with fibrous dysplasia, sphenoids?
Yeah, the sphenoid is tricky. It's actually the very most common place to have fibrous dysplasia for some reason. Most of the kids have it there. The skull FD, it really only will cause problems if it expands out. So it commonly causes facial asymmetry, but fortunately, it doesn't tend to compress the nerves as frequently as you'd expect. With patients that have it in their entire skull, and their brain will be fine, there'll be no compression in there. It tends to kind of grow out and away from the nerves. So I try hard not to mess with the skull if we don't have to. My motto that I always like to repeat is there's no problem so bad that a surgery can't make it worse. So we try to be as conservative as we can. The main risk for the craniofacial FD is really growth hormone excess. Even a very small amount of growth hormone excess can lead to the skull expansion. And I found that in FD-MAS, because so many things can impact height, that growth velocity is not a sufficient screen for growth hormone excess. We have plenty of very short patients that still have growth hormone excess and have severe skull disease. So I'll get an IGF-1 once a year, and really regardless of growth velocity. One thing to be careful of, though, is if the precocious puberty is not controlled, it will drive the IGF-1 up just because of the sex steroids. So you have to make sure that that's controlled in order to interpret the IGF-1.
Zalak, do we have time for any more questions? Or
Yes, ma'am. Maybe one more, one or two more.
So this one is if a patient presents with café spots precocity, initially ovarian cyst, and within 6 months develop central precocious puberty, how to look for fibrous dysplasia? Patient has no symptoms. Can we do a bone scan?
Yeah, I'll show that in my talk too. I think a bone scan at age 5 or older is very helpful diagnostically. You will see any fibrous dysplasia that is ever going to cause a problem will show up by age 5 in some form on a bone scan. So I think it's helpful to do that even in kids who are asymptomatic, because it will empower the patient to know where those bone lesions are, and then you'll know what needs to be monitored moving forward.
Some more questions about the lifespan, fertility, but I think most of that you'd cover in your talk for us.
Yeah, I actually focused a little more on the bones, but I can say in fertility, again, for the women, they probably have delayed time to conception because of the cysts, but certainly are capable of becoming pregnant and carrying a pregnancy. So at this point, I don't think there is any reduced fertility for a month they're ovulating. The only issue is they ovulate less frequently because of cysts. Not aware of any reduction in fertility in men in what we can see, but it has not been studied very rigorously. It does seem to me if in the boys that have precocious puberty, I have seen in adult men, sometimes they will still have high testosterone and reduced gonadotropins because of autonomous testosterone production. So I do think it's possible there may be a fertility issue, but precocious puberty is so rare in the boys with MAS, and MAS itself is so rare that I just haven't encountered that yet. And lifespan seems to be normal. The only things that really can be fatal disease related are progressive scoliosis can lead to lung failure. We have lost some patients from that. And there is about a 1% chance of developing osteosarcoma at some point if you have fibrous dysplasia. And unfortunately, it can be quite aggressive. So that's another one of the things that we have lost patients prematurely from. But other than that, my oldest patient lived to be 103. So it's, yeah.
Good to hear.
Mhm.
Okay, thank you, Praveen. It was a very good case and a lot of discussion. So I think now we can progress to our main speaker. That's Professor Alison Boyce, who's going to talk us through McCune Albright. And she's a pediatric endocrinologist, and she's a chief of the Metabolic Bone Disorder Unit at the National Institute of Dental and Craniofacial Research, National Institute of Health. This is based in USA. The goal of her work is to enhance health and well-being of children with skeletal disorders by developing novel tools and treatments informed by pathophysiological studies. She leads the investigation in fibrous dysplasia, McCune Albright syndrome, which is a very rare disease affecting the bone and endocrine system, which we've heard in 2 cases that have been presented. Dr. Boyce is a faculty member in the NIH Endocrinology Fellowship Training Program. She's a member of the Fibrous Dysplasia McCune Albright Syndrome International Consortium and serves as a chair of the Medical Advisory Committee to the Fibrous Dysplasia and McCune Albright Syndrome Alliance. So we're handing over to you, Professor Allison. So we're looking forward to your talk.
You, let's see. Does that look okay?
Yes.
Great, great. Well, thank you very much for the invitation to speak. I'm really happy to be here and discuss my favorite topic with with interested folks. It's always a nice way to spend a Saturday. So these are my disclosures. So as we've heard, fibrous dysplasia McCune Albright syndrome is a complex mosaic disorder of G-alpha-S activation. It can involve any part or combination of the skeleton and many parts and combinations of the endocrine system. So this complexity makes FDMAS a really fascinating disorder to try to understand G-alpha-S and the different systems that it affects. However, it creates a really challenging situation for clinicians because we have the difficult job of trying to make a diagnosis and a management plan in a disorder where no 2 patients look alike. So as we've heard, FDMAS arises due to gain-of-function mutations in the alpha subunit of the GS G-coupled protein receptor. So this is a receptor that's responsible for signaling in multiple different tissue types, but especially the bone and endocrine system. So in the mutant state, the GTPase activity of this alpha subunit is lost, and the receptor essentially gets stuck in the on position. So it's the increased signaling through the different tissue types that the receptor affects that leads to the clinical features of the disease. So increased signaling through the melanocyte stimulating hormone receptor leads to skin hyperpigmentation. Increased signaling through the LH and FSH receptors leads to precocious puberty. Patients can have overproduction of growth hormone, thyroid hormone, etc. I always tell the fellows that if you really understand McCune Albright syndrome, you'll never have to memorize which hormones signal through the G-coupled protein receptors because it's the list of them is up right here. So a really key aspect to understanding FDMAS is that this is a mosaic disease, and that's reflected in its clinical features. So the skin lesions occur in this classic distribution along the midline of the body, kind of reflecting there with these characteristic jagged borders. And these reflect developmental lines of Blaschko or the patterns of early embryonic cell migration. The bone lesions are very patchy and mosaic. They can range anywhere from trivial disease affecting only 1 or a few bones to severe disease affecting nearly the entire skeleton. And the endocrine gland involvement is patchy and mosaic as well, which you can see here in this patient who has unilateral testicular involvement. A really key aspect of mosaic diseases is there's never been a case of vertical transmission. So this is not a disease that is passed between parent and child. It's not inherited. That probably reflects the fact that if you had a germline mutation in this gene, so a mutation that affected every cell in the body, it's probably not compatible with life. So these mutations probably only survive through mosaicism. And this picture shows our current understanding of how we think FDMAS arises. So very early in embryogenesis, a mutation occurs by chance. And then the progeny of this mutated cell spreads throughout the developing fetus, forming tissue that will ultimately be affected by disease. So when we have a patient who has a phenotype that involves tissues that are derived from all three germ layers, so the ectoderm, mesoderm, and endoderm, which comprise the bone, skin, and endocrine systems, we know that that inciting mutation had to take place very early before those three germ layers split. So in bone, G-alpha S mutations impair the differentiation of skeletal stem cells. So these are multipotent cells that normally differentiate on a number of different lines. So they can turn into osteoblasts or bone-forming cells, chondrocytes or cartilage cells, fat cells, or stromal cells that support hematopoiesis. However, in the case of a G-alpha S mutation, this differentiation process is disrupted, and the cells instead form these kind of abnormal osteoblasts. And this is what leads to the appearance of FD. So you can see in comparison to normal bone, where you have this nice organized bone compartment with this organized lamellar bone and this nice organized marrow, in FD, all those structures are disrupted. Instead, the marrow cavity is filled with this kind of expansile, junky looking fibrous tissue. When bone is made, it's very disorganized. It's this woven bone, which you should only see during fracture healing and things like that. And it's really poorly mineralized, as you can see here by this red unmineralized osteoid. So we think this probably reflects that these abnormal osteoblasts are just trying to form a bone. They're dividing and dividing and dividing, and they just can't. And when they can form a bone, it's just not very normal bone. So they fill the marrow cavity and expand out with this just proliferation of these undifferentiated cells. So osteoclasts are bone resorbing cells. They're derived from the myeloid lineage. We see them scattered all throughout the FD lesions, and I'll get back to them a little later in the talk and what we think they're doing here. So most of the data that I'll show today comes from our natural history study in FD-MAS at the NIH. So this is a long-term study. It started in 1998. I'm actually the third PI of it. We've enrolled greater than 300 patients, and our goal is to follow them over time to define the disease spectrum and the disease course, to determine the standard of care treatments, and to ultimately support the development of new drugs and new trials. And this is a complicated picture, but it shows a typical course of what patients experience at NIH. They get admitted to our clinical research hospital on a Monday, where they have a history and physical exam. Then they undergo a standard set of tests, so skeletal imaging, endocrine imaging, blood work. They'll see a group, different specialists depending on what their disease features are before being discharged on a Friday. So one of, I think, the more important observations we've been able to make on that study are that FD has a very key age-related phenotype. So I shared a few slides ago that the mutation that causes FD-MAS arises very early, while babies are still in utero. But interestingly, at birth, there's usually not any obvious signs of fibrous dysplasia. So that means that bone formation in utero seems to take place pretty normally. The FD lesions become apparent clinically during the first few years of life, and then they continue to expand and new lesions continue to appear till about sometime between age 15 and 20. And then patients have all the FD they're ever going to have. We think that that probably means that those, babies are born, they have the mutation present in their bone lesions, but it takes some time for those abnormal cells to divide enough to form a lesion that we can really see. So interestingly, there's also seems to be an age-related phenotype in adults. The FD lesions in adults, we think, become less active. You can see that because bone turnover markers gradually start to decline as patients get older. And if you do a biopsy of a bone lesion in an older adult, sometimes you can even start to see some normal marrow forming within those FD lesions. So we think that probably means that the skeletal stem cells that have the mutation may not live as long as a normal skeletal stem cell, and the lesions will just undergo apoptosis or senescence over time. I will say, though, a lot of patients think this means that their FD is going to get quote unquote better as they get older. But most of the problems from FD arise because the bone expanded or bowed or formed abnormally. And unfortunately, even if the lesions get less active over time, the bone is not going to return to a normal size. So it continues to be a problem in adults. So the complications of fibrous dysplasia depend a lot based on where you have the bone lesions and how extensive they are. And clinically, it's useful to divide the skeleton into kind of three main compartments. The craniofacial skeleton, or the skull and jaws, the axial skeleton, which is the spine and ribs, and the appendicular skeleton, which is the limbs. And in the skull, most of the problems of fibrous dysplasia arise because the lesions expand. So this can lead to facial asymmetry in most patients, and if it involves vital structures, can lead to functional problems. So if it involves the temporal bone around the ear, patients can get hearing loss. If it involves the jaws, the teeth, you can have malocclusion where the teeth don't line up correctly. It can lead to problems with eating and chewing. And if it involves the optic canal that surrounds the optic nerve, it can lead to vision loss. This is really difficult to manage in the skull. The surgeons are very tempted when they see this asymmetry to just go in and shave the fibrous dysplasia down and make things more even. But unfortunately, the FD tends to regrow after surgeries like that, especially in kids. So we try to avoid any surgery for facial asymmetry until adulthood, and really only if it's quite severe and disabling. I think the most important thing to know about the skull is to never do a surgery for a problem that hasn't happened yet. For example, surgeons will often want to go and tunnel out the optic canal because they're worried the FD is going to cause vision loss. And we never recommend doing that in a patient unless the vision loss is already present, because you're more likely to actually cause damage to the optic nerve with the surgery than if you just left the FD alone. In the axial skeleton, most of the problems happen due to scoliosis. In rare cases, the scoliosis can be quite progressive and potentially even lethal. It's definitely something to monitor for. One of the biggest risk factors for developing scoliosis is leg length discrepancy. So if one leg is shorter than the other, the body will try very hard to keep the head straight. So it will end up tipping the hips and tipping the shoulders. And this can put more pressure on the spine. So sometimes something as simple as a shoe lift to correct leg lengths can be very important to protect the spine. Interestingly, surgery to fuse the spine in FD shows pretty favorable outcomes, kind of similar to other skeletal disorders. So I would have a low threshold to send these patients to the orthopedic surgeon if the scoliosis is progressing. And in the limbs, most of the problem arise because the fibrous dysplasia either breaks or it bows under weight-bearing forces. And the biggest problem is always the femurs. This is the proximal femur up by the very top of the shaft. And here you can see a patient who has the classic shepherd's crook deformity, where this angle tends to bend. And that's because the proximal femur is where the body is holding up all of the weight to when you stand straight, and it's being asked to do this at an angle. So it puts a lot of stress and strain in this area. Again, patients who have pain in the femurs, I think it's really important that they see the orthopedic surgeon to make sure that that's not an area that's about to break. We recommend surgery in patients that have consistent pain in their femur with weight bearing. If every time they take a step, they say it hurts right here in my leg, that's usually a sign that it's orthopedic pain and that they're going to have a fracture if something's not done. Any kind of bowing deformity that leads to problems with the gait, or if the femoral neck bows like less than 110 or more than 150 degrees, usually surgery needs to be done before it progresses too much farther, and then it's difficult to correct. And the patients tend to respond really well to these intramedullary rods. Like bone graft is less effective here. The surgeons often love to just scoop this fibrous dysplasia out and pack it with a bunch of graft because they think that will be stronger. But unfortunately, the graft just gets eaten away over time. So really, these type of implants are much more effective. So this is our current approach to screening in fibrous dysplasia. I think someone had asked a question earlier about bone scans, and this is what I was referring to. So the way we work up FD depends a lot on the patient's age. Of course, you always start with a targeted history and physical exam, asking about any bone pain, any limp, any lumps or bumps in the skull. And from there, the approach really varies depending on their age. So if they're less than age 5 years, and you don't have any obvious suspicion for FD, so they're not reporting any pain or fractures, you can just monitor those kids for now. But if at if at age less than 5, they've already had a fracture or they have pain or limp, you want to go ahead and get x-rays to look for any lesions. Once they're age 5, things become a lot easier because by age 5, if they're going to have FD in any area you care about, like the femurs or the skull, you'll be able to see it on a scan. So we recommend doing a bone scan in everyone with MAS or suspected MAS at age 5. If that bone scan is abnormal, then you follow up those areas of FD with more targeted imaging, like x-rays if it's in the limbs, or a head CT if it's in the skull. If they have a normal bone scan at age 5 or older, the good news is you can probably stop worrying about any fibrous dysplasia, and you don't need to do any more routine imaging. Often I'll get asked if instead of a bone scan, could we just do x-rays? They're easier to do and they may have less radiation. Unfortunately, x-rays just aren't good enough to pick up FD in either the skull or the spine and ribs. Unfortunately, I think we really do need to do a bone scan in order to completely stage where someone does or does not have FD. All right, I'm going to switch gears a bit and talk more about the endocrine features that we've heard about some this morning. So the endocrine features of McCune-Albright syndrome are one of the biggest risk factors to make the skeletal disease worse. We have seen this every way we've looked at it on our natural history study. So hyperthyroidism and hypophosphatemia are associated with higher fracture rates. They're both associated with having a higher risk of scoliosis. Hyperthyroidism and hypophosphatemia are also both associated with basilar invagination. So that can happen when the skull base kind of deforms around the top of the spinal cord because it's kind of weaker and folds under weight-bearing forces. So this can lead to dangerous neurologic problems. And then growth hormone excess is associated with a higher risk of both vision and hearing loss because it increases craniofacial FD expansion. So I just wanted to emphasize this relationship between growth hormone excess and craniofacial FD, because I think it's really important, and it's one area where we as the endocrinologists can have a big impact on the bone disease. So these are two patients that both have equal, at the top and the patient at the bottom, they both have equal amounts of craniofacial FD, and they have equal severity of growth hormone excess. The patient at the top was not screened for growth hormone excess until age 18, so he didn't receive any treatment. And you can see he has just massive overgrowth of his skull, particularly here in the jaws. He has occlusion of both his optic canals, so he is unfortunately blind, and he also has some hearing loss. This patient on the bottom was screened with IGF-1, and she was started on treatment for growth hormone excess at age 9. And you can see that overall her skull is relatively symmetric. She has wide open optic canals, normal vision, and normal hearing. So this is a really important one to screen for. So talking a little bit about FGF23, as we heard this morning, FGF23 causes renal phosphate wasting. And it's actually made by FD cells. So the bones, the abnormal bone cells themselves will overproduce the FGF23. So because of that, the amount of FGF23 that you see in a patient's blood is pretty parallel to the amount of FD that they have. So while almost all patients with FD will have some increase in FGF23, it's usually only the patients that have a lot of FD that make enough FGF23 that it's actually going to cause their phosphorus levels to go low. That's one reason we have to keep an eye on phosphorus levels, is because especially in kids, as their FD expands and they develop more bone lesions, their phosphorus levels can go down as they get older. So one of the observations I've just made from taking care of a lot of patients with FD is that the low phosphorus is one of the biggest risk factors for worse skeletal outcomes. And I had this sense that even the patients that have low normal phosphorus levels seem to do worse than the patients that had like high normal phosphorus levels. So we wanted to look at that more carefully in our cohort. So we kind of divided the patients into frankly low phosphorus. So this is phosphorus like below the normal range that anybody would call hypophosphatemia. Then low normal phosphorus, so phosphorus between like a age-adjusted z-score between -2 and -1. And then high normal phosphorus, so in the kind of middle to upper part of the normal range. And interestingly, it showed exactly what we suspected, that the patients with a high normal phosphorus had the lowest fractures and the lowest rates of orthopedic surgery, even compared to the low normal phosphorus. So, and the reason this matters is because, burosumab, an anti-FGF23 antibody, is a treatment that's been around for a newer treatment that's been around for a few years that allows you to actually target a certain phosphorus level. So we're conducting a trial of burosumab in patients with FD right now at the NIH. And as part of this study, we are targeting phosphorus levels kind of in the upper part of the normal range, kind of based on our natural history data. So this is a study that's going to be done soon. Actually, our last patient is finishing up next month. So I'm very optimistic that this will be a better treatment for hypophosphatemia and FD. Unfortunately, it's very expensive and hard to access this medication, but I think hopefully as time goes by, this will be a real advancement in care. So I'm going to switch gears a bit and go back to the osteoclasts. As I shared earlier in the talk, they're bone resorbing cells. They come from the myeloid lineage, and we see them just distributed all throughout the FD lesions at kind of a higher rate than you'd expect in a normal bone. So that causes us to ask the question, could targeting these osteoclasts with anti-resorptive medications be effective treatment for FD? So the easiest way to target osteoclasts is with bisphosphonates. So a number of years ago, we did a clinical trial using the oral bisphosphonate alendronate in patients with FD. And in this study, we found that alendronate treatment led to a reduction in the bone resorption markers in the blood compared to placebo, but we didn't see any change in our bone formation marker, osteocalcin, with treatment. And recall that FD is a disorder that arises due to problems in osteoclasts, so bone forming cells. So really, bone formation markers should be a better reflection of what's going on in an FD lesion. So that was disappointing. We also didn't see any changes in pain, any changes in fractures, no improvement in their physical performance, and no change in radiographic appearance of FD lesions. So overall, kind of a bit disappointing results. We then asked, well, we know that in kids, FD lesions are expanding. So if we treat kids with bisphosphonates during that period, could we at least stop the FD lesions from growing? And the answer seems to be no. We looked retrospectively at patients in our natural history that got really high doses of bisphosphonates during childhood, and there was no change in the progression of their lesions compared to kids that did not get treated. And then also the group in Montreal published a really cool paper where they treated kids with FD with pamidronate, the IV bisphosphonate, and they actually did biopsies of their FD lesions before and after treatment. And they did not see any change in like the composition of the FD lesions at all with treatment. Also, concerningly, we started to see some cases of osteonecrosis of the jaw in our patients at NIH who were receiving bisphosphonates. So putting this all together, just don't think there's any evidence to support that the bisphosphonates will improve the bone quality in FD or reduce fractures or prevent their expansion, unfortunately. However, there is evidence that IV bisphosphonates can be helpful for bone pain. It seems to be helpful for treatment of many different kinds of bone pain. So I do think it's reasonable to use them for that reason. But as I shared, I think it makes sense to use the lowest dose and the longest interval that you need to achieve pain relief. Okay. So, however, there is another way of targeting osteoclasts, and this is something we're working on now. So, rankle is a protein that's made by osteoblasts and osteoblast precursors. It binds osteoclast precursors and activates the maturation of kind of mature osteoclasts. So for a number of years, we've had evidence that rankle seems to be playing a role in FD pathogenesis. We see high rankle levels in the blood in patients with FD, and these rankle levels seem to correlate with how much FD someone has. And if we look at FD tissue, we see that it makes a lot of rankle, as you can see here in these kind of brown areas of rankle expression. And what's interesting is the rankle expression seems to be highest in the areas of FD that are most active, where the cells are proliferating a lot, as you can see here with co-staining for Ki67, a proliferation marker. So, and this is important clinically because rankle is something we can target with a medication. Denosumab is a rankle monoclonal antibody that prevents the rankle from binding to its receptor and prevents the differentiation and fusion of mature osteoclasts. So we hypothesized that rankle inhibition with denosumab might be a novel treatment strategy to reduce FD lesion activity and hopefully improve the bone formation within the FD lesions. So to study this, we performed a phase 2 study of denosumab in adults with FD. So in this study, we treated them with very high dose denosumab for 6 months. We chose we treated them with 120 milligrams monthly with loading doses on weeks 2 and 3. So that's the dose of denosumab that was developed to treat bone tumors. And we chose that because FD is kind of at its essence a benign bone tumor. So one difference between denosumab and bisphosphonates is that denosumab's action is transient. So while you treat a patient with denosumab, you can have a buildup of these pre-osteoclasts. And when the denosumab is stopped, there can be a big surge of bone resorption with a rebound period after the medication is stopped. So we really wanted to investigate not just how effective FD was at treating FD, how effective denosumab was at treating FD. We really wanted to also investigate the safety of stopping denosumab. So we had this long post-treatment discontinuation period where we watched patients closely. And then our primary endpoint on this study was the effect of denosumab on bone turnover markers. We also looked at lesion activity using bone scans, pain and function, and then we did FD bone biopsies before and after treatment. So here were the results. In the denosumab treatment led to a huge decline in bone turnover markers. And interestingly, our bone formation marker declined just as much, if not more, than our bone resorption marker. And recall, this is a big difference from our bisphosphonate trial where we weren't able to affect bone formation markers at all. So this really was a sign that we were having some effect on the FD lesions. And then what was exciting is we saw a huge decrease in lesion activity on bone scan These scans are sodium fluoride PET CT, so they're combined functional anatomic scan. And essentially the amount of tracer that gets taken up into the FD lesion is a sign of how active it is. And you can see with 6 months of treatment, there was a huge decline in tracer uptake in these lesions. And I think what was even more encouraging is that this was also associated with an improvement in the patient's function. So this patient down here at the bottom who has really severe FD in her ribs, you can see from all this black uptake, she had such huge expansion of the ribs, compromising her lungs, and she required continuous oxygen therapy. And after starting denosumab, her lung function actually improved and she was able to stop the oxygen. So that was really encouraging. And on the biopsies, we saw really interesting things. So these images at the top were before denosumab, and then again after 6 months of treatment. You can see after treatment, we saw formation of these kind of more mineral content in the lesions. So these smooth pink areas are signs of mineralized bone forming within the fibrous tissue. We saw reduced expression of a cell proliferation marker, MCM2, and increased expression of this mature mineralization marker, SOST. So I think this is what this is telling us is that when we treat patients with denosumab, these FD cells, which are kind of stuck in an immature state of differentiation, they stop dividing so much, and they also adopt a more mature differentiation pattern. And basically, at the end of the day, they're able to make more bone. So I think that's really what's helping the patients. So conclusions from this study is that if we block rankle, it reduces the proliferation of these abnormal osteoprogenitor cells and increases their maturation so they can make more bone. So this supports a potential therapeutic role of denosumab in FD and highlights how important this communication between the osteoclast and FD cells seems to be as a driver of the disease activity. So that was really exciting. However, we did run into some big problems with bone turnover rebound after stopping denosumab. So in all of our patients, we treated them with zoledronate at the time we stopped denosumab to try to reduce that bone turnover. But in 4 patients, the CTX levels still increased above pretreatment levels. And in 1 patient, this was associated with really severe hypercalcemia. So 23 milligrams per deciliter, which is the highest calcium I've ever seen. So this patient needed to be hospitalized. She was treated with fluids, bisphosphonates, and an additional dose of denosumab. And her calcium level came down beautifully without any problems, and she recovered well. But still, obviously, a really important side effect that we need to be aware of. So denosumab for treatment of FD, where are we now? I think there's really exciting potential for effects on FD lesion activity and composition, but this severe post-discontinuation hypercalcemia does occur in some patients and is a really important limitation. So there's some really important questions we still haven't answered. Who should we treat? How long should we treat them? And what is the optimal dose that we should use? I don't think this is going to be a medication for everybody with FD, but it is an important option for patients that have really severe disease that can't be controlled other ways. And I think the really potent effects we saw with only 6 months of treatment with our high dose trial is a sign that we probably don't need nearly that much denosumab to have an effect on FD. So we can probably get away with much lower doses. So further study is needed to determine if or how to use denosumab in FD, and that's particularly true in children. So this is the same graph I showed earlier, where during childhood, the FD lesions are continuing to progress, and that all of the FD is established sometime between age 15 and 20. So what I think this provides us is with a window of opportunity where if we can find a treatment that will prevent FD lesions from expanding in kids, that's how we could have a really transformative effect on the disease. So we're trying, right now we have a phase 2 trial of low dose denosumab in kids to see if we can prevent lesion progression. This is in enrolling 15 kids age 4 to 14. And our primary endpoint is going to look at the effect of denosumab on lesion expansion compared to untreated kids in our natural history study. We're using a really low dose, 0.25 milligrams per kilogram, and we're giving it monthly. And the reason for that is, kids have much higher bone activity, so they tend to rebound much faster from denosumab. So we wanted to treat them continuously so they wouldn't rebound between doses. We wanted to use a much lower dose because if we're going to treat kids over long periods of time, we've got to try to reduce the toxicity as much as we can. So this dose is kind of equivalent to like a Prolia osteoporosis dose, but it's given once a month. And this study has finished enrolling, so I'm hoping to have data to share probably within, in about a year. Thanks very much for your attention. I think that was just a kind of a brief high-level overview, and I'm happy to talk in more detail about any other questions. Just want to acknowledge my group who's been just really amazing at getting this work done, and of course our patients. They're really just a wonderful patient community, really motivated, and it's just been a pleasure to work with them. So thanks very much.
Thank you, Dr. Allison, for that wonderful talk. I think there are a couple of questions which I will put. Can McCune present without cafe au lait spots?
Oh, it absolutely can. That's one of the trickiest things. McCune-Albright syndrome can look like anything. You can have a really large, impressive skin spot and nothing else. You can have really severe FD and no skin spot. People often wonder if you have your skin spot on one side, does that mean you're going to have FD on that side? No, not at all. There just doesn't seem to be any correlation there.
What are the pointers in hypophosphatemic rickets and normal germline genetic testing to suspect FD or McCune-Albright?
So is it...
What are the pointers in hypophosphatemic rickets and normal germline genetic testing to suspect fibrosis McCune-Albright?
So I almost never get genetic testing, honestly, for patients. It's because it's a mosaic disease. If you, it's very difficult to find the mutation. The odds of finding it are quite good if you have affected tissue. With the exception of skin, it is very hard to detect the mutation in a skin biopsy because the mutation is, the cells that have the mutation are the melanocytes, and there's not many melanocytes in a skin biopsy. So in order to get a positive genetic test, you really have to have a piece of bone or a piece of ovary or thyroid. That's very invasive. No one wants to do a biopsy in a kid. So most of the time, it's a fairly easy diagnosis to make clinically if you know what you're looking for. So the only time I recommend getting genetic testing would be, in particular, if you have, for example, a monostatic skull lesion or just a single bone lesion with no other signs of disease. I do think in that case you want to do testing if you can, because you wouldn't want to miss, for example, some other type of bone tumor that just looks like FD. But other than that, I really almost never get it, because if it's negative, it doesn't really change what you're going to do. And the rickets, the rickets is tricky. So the phosphorus levels can just go up and down in these patients. I think one of the biggest factors is the amount of phosphorus that you need changes a lot over the course of your life. The more you're growing, the more phosphorus you need. So it's very common for me to see there'll be a kid who will have a phosphorus that's kind of in the low normal range, like 3.6, 3.7. And they will be going along fine, no rickets, doing okay. And then all of a sudden they'll turn like 12 or 13, and all of a sudden they have a bunch of bone pain and they're miserable. And then we check it, and the phosphorus is still like 3.6, 3.7, but now the normal range is higher. So they've sort of slipped into hypophosphatemia. So we'll treat them for a bit. Then when they're done growing and they're an adult, the normal range for phosphorus goes down to 2. So they may not need to be treated for the low phosphorus as an adult. But it's interesting. It just looks different ways, different times. So I think whenever you have a kid with bone pain, you want to check that phosphorus because it can fool you. That the phosphorus can really make the FD pain feel worse. Sorry, 1 second. I have a little invader here. I'm sorry. Sorry about that.
Not at all.
So there's a question about denosumab. What is the mechanism by which denosumab reduces the activity of the abnormal osteoblasts and fibrous dysplasia lesions, as opposed to bisphosphonates that do not, despite having the same final common pathway?
Yeah, wonderful question. I really wish I knew. I have some ideas. So, yeah, it is. I was shocked to see that the denosumab will have such huge effects, whereas the bisphosphonates don't. I think probably what's happening is that the osteoclasts, they don't have the FD mutation. It's only in these osteoblasts. But if you wipe out the osteoclasts with denosumab, everything calms down. So I think what's probably happening is the osteoclasts and the osteoblasts have some signaling between them. It's kind of messed up and it's driving the FD lesions. Bisphosphonates, I think, probably aren't working because they need to be incorporated into a bone to do anything. So they get like taken up into the bone scaffold, and they stay in there for many years, and they inhibit osteoclast that way. I think in the FD, it's just so fibrous and so poorly mineralized, then maybe that the bisphosphonates aren't even penetrating into the FD lesion, and that's why we don't see any effect. What I think would be interesting is if that's true, what might be good is if we could give denosumab first and we could mineralize that lesion. Is it possible that we could then start treating with bisphosphonates? And like maybe they would get into the lesion that way. I would really prefer that because denosumab is a very scary drug and it has all these side effects. And I would much rather be able to use a drug like bisphosphonates where we don't have to worry about this rebound and there's more safety. So I think that's something we'll have to try to work out as part of our trials. But the problem with these bone altering drugs is it takes a long time to see any effects. So I think it'll be a number of years before we know for sure.
You. That's it with questions. Oh no, was rushing with that. If in an apparent garden variety hypophosphatemic rickets and no skin lesions, when to consider McCune? Should we get a bone scan then?
I think that would be very unlikely to be fibrous dysplasia because in FD, the FD cells don't make that much FGF23, just a little bit. So in order to get an actual rickets, you have to have a lot of FD. I have never seen hypophosphatemia in a patient with monostatic FD with only one lesion. I've had a few patients come with that diagnosis. They'll have just like one arm lesion and low phosphorus, and they're calling it McCune. But every time I've seen that, when we do a biopsy, it turns out not to be FD. It's actually a tumor-induced osteomalacia, where patients can get like another bone tumor that makes lots and lots of FGF23. Also, it's in garden variety rickets, it's much, most of the time it's vitamin D deficiency. And the next most likely is probably going to be like X-linked hypophosphatemia. So usually the rickets will not surprise you. Those kids usually have a lot of other problems already related to the fibrous dysplasia and other endocrine issues.
Another question. This is about a patient who's already on Albright monthly. LH initially got suppressed for 4 months and then became non-suppressed. Bone age is advancing. What should be the line of one's management in this situation?
Oh, so would this be a patient with MAS on Lupron?
I think so. That information isn't here. I'm assuming that would be the case.
Yeah, so in the patients with MAS that have central precocious puberty. It's almost always an effect from their peripheral precocious puberty. So they start with the typical MAS puberty, so either ovarian cysts or testosterone production from the testes. And then because their brain sees so much of this sex steroid, it can trigger central puberty. But in those cases, Lupron can be helpful, but you also have to continue treatment for the peripheral puberty too, because essentially what they now have is two types of puberty, not just central. That might be the issue.
Any more questions? That is with the questions. I think I'll thank you, Sir Alison. I'll hand the mic back to Dr. Ahila. The closing session.
Thank you so much, Professor Alison Boyce. It was absolutely wonderful. I think it was a treat for all of us, and it will help the management of our children in a much better manner. And I think you will have a lot of inquiry from our pediatric endocrinologists in India asking for help. And we hope we don't trouble you too much.
Oh
Thank
no,
you so
happy
much.
to.
I mean, if you look at the collective children that would have McCune Albright, we may be missing a lot. The numbers are usually huge in India, whatever you talk about. So we will have various difficulties in our children, and we will reach out to you. Thank you so much for sharing that wonderful experience, and we will watch and look forward to your upcoming guidelines in the improvement in what all you tried and which would help our children. Thank you so much for sparing time on a Saturday, and it's absolutely wonderful. We really appreciate your time. Thank you so much, Leenata and Shalmi, for leading that so well. And Praveen and Akshata, you did wonderfully. I mean, you really did very, very well, and it was extremely interesting. And thanks to your mentors from your institutions too. And I'm handing over the vote of thanks to Zalak. Thank you, Zalak. As always, you stand like a pillar. Thank you.
Thank you, Ahila ma'am. You are the brain behind this, searching the topic and the speakers. Thank you so much. On behalf of Team ISPAE, I would like to convey our appreciation for the contribution by our expert today, Professor Alison Boyce. Your work is commendable and it's very impressive. So we'll be looking forward to the guidelines, the upcoming guidelines on McCune Albright. Thank you to our mentors, Dr. Shalmi Mehta and Dr. Leenata Reddy. You are wonderful and you led the discussion so well. Thank you so much. And thank you, Dr. Praveen and Dr. Akshata for presenting the cases so well. We thank all the delegates who have joined today. We had many questions and the discussion was very fruitful. The next ISPAE ACES meeting will be the series 30th, which will be in December. Do join us. Thank you, RX event team, for the smooth proceedings. Thank you, everyone. Good night.
Thank you. Good night.
Thank you, Professor Boyce. Thank you once again.
Thank you.
Thanks, everyone. Bye. Good night.
Bye-bye, everybody.
Recording stopped.